Hello and welcome to week 2, lecture 2. We are going to pick up with aminoglycosides. As you recall, we're talking about those medications that interrupt the 30S ribosomal subunits, interfering with messenger and transfer RNA and subsequent cell wall disruption of bacteria. So let's jump right into it and begin the discussion. There we go. We'll minimize me and put me up in the corner and maximize. Okay, let's get going. So aminoglycosides, remember the pharmacodynamic killing principle? Remember we talked about time dependent and concentration dependent. Well, no doubt this is a concentration dependent. So how we dose them are slightly different. Your prototypical drug for a gram-positive synergistic perspective is going to be gentamicin. For a gram-negative, it's going to be tobramycin, but neomycin is used topically. Also in ear drops, ophthalmic drops. Then we have plazomycin, which is I'm going to use the word newer generation aminoglycoside. It's very expensive, but it has a place. It certainly does, and I'll kind of tell you where that. I think patients who have recurrent urinary tract infections, after you've treated 3, 4, or 5 of them, I think you really need to go with this. And hopefully I remember to tell you the why. But the Tobradex, the tobramycin, the Toby are the inhalational solutions. The Tobradex or the Tobrex and the Tobradex, those are drops. For the Tobradex has dexamethasone mixed with it. The Tobrex just has the tobramycin that can be used for various infections topically, if you will. But the big use is certainly intravenous. We don't use aminoglycosides like we used to. Now, a couple points I want to make right now. You can use an aminoglycoside monotherapy if it's a UTI. We're getting some better information that may be in bacteremias, but remember, aminoglycosides have a small volume of distribution. So while they concentrate in the urine, because that's how they're eliminated, so cystitis, right? That's okay. But they don't distribute to the tissues. And that's a problem because you can't get high enough concentrations to treat the infection solely with an aminoglycoside. And with that said, when we do use it, it's usually in combination for even with Staphylococcal bacteremias. While you'll see some guidelines that say do it, most of them have dropped. For example, gentamicin, and the reason being for staph bacteremia is because while you do get sterile blood culture sooner than later, it has no effect on mortality or morbidity. So with that being said, you do introduce the risk of nephrotoxicity with aminoglycosides, and not giving it, you eliminate that risk, at least as it relates to an aminoglycoside. So spectrum activity, again, monotherapy, it says gram-negative only, but no, we do with gentamicin do synergy. But for the most part, we use these for gram-negative bugs. But for monotherapy, it's only going to be, you do get Pseudomonas coverage, and you can get multi-drug resistant Enterobacteriaceae coverage, but it's only going to be in the setting really of a UTI. Even with bacteremias, with plazomycin, I feel more comfortable if that was the case, but you don't get as good Pseudomonas coverage with plazomycin. So only a UTI. Every other thing, this is going to be used as double therapy or synergy. The combination with gentamicin, remember with Enterococcus endocarditis, we talked about that, specifically Enterococcus faecalis. We would give ampicillin to cover that, the Enterococcus faecalis, not faecium, that's usually vancomycin resistant. But we would give the gentamicin with that. But remember, we have now found out that we can use the 3rd generation ceftriaxone, which doesn't cover Enterococcus, but when given with ampicillin, creates synergy. And we've actually been able to drop gentamicin from that protocol, which substantially decreases the risk of nephrotoxicity. So that's a good thing. That's specific to Enterococcus faecalis endocarditis. And remember, this would be one of the exceptions where ceftriaxone, brand name Rocephin, would be dosed at 2 grams every 8 hours. But you're not going to get MRSA coverage, nor atypicals, nor your anaerobic coverage. But this is the Zimdri. This is the plazomycin. It is similar to other aminoglycosides, but there is a structural change which allows it to be active against some carbapenem-resistant organisms. Now, Its Pseudomonas aeruginosa activity isn't overly impressive, but it does give you some CRE activity and some others. There are some places with it. This is one drug that if I had extremely drug-resistant CRE, I would be giving it in combination with the Avicaz or the Vabomere or the Ricarbrio. I'd be giving this in combination for a deep-seated infection, not by itself, but whether it be the lung or the blood, the bone, whatever it may be. That's something I can do, and because of the benefits of some of the studies out there. But it's an interesting drug, but it's outpatient drug for sure. It's going to take a prior authorization, and it's pretty pricey. So the infections we treat with aminoglycosides, for the most part, they're going to be along the lines of gram-negative infections. Again, from a gram-positive perspective, we do deploy in synergy sometimes gentamicin, but that has fallen out of favor with methicillin-resistant Staph aureus. And with Enterococcus, it's more and more every day falling out of favor and being replaced with Rocephin, the ceftriaxone 2 grams Q12. So keep that in mind. We don't see it as much, but you can see here, there's its spectrum. And yeah, you get good tobramycin. You get better with amikacin or tobramycin. You're going to get better gram-negative coverage. Same down here, but you do get pseudomonal coverage, yes. But I would be using, if I was going for a gram-negative, I'm using tobramycin, and I'm going to keep my gentamicin just for maybe synergy for Enterococcal faecalis. And really, again, we have found that you do convert your cultures to negative sooner. You add gentamicin, but again, the studies didn't show a benefit to the patient. So you were just treating a number. The outcome was the same, sterility of the blood and a cure. So the mechanism of action, again, remember clean tag. So these are going to bind those 30S ribosomal subunits, and they go through poron channels on the outer membrane. So this is one area. You can get some enzymatic resistance with aminoglycosides, but again, poron channel alteration, and you no longer get penetration into the bacterium, so it can bind to those 30S ribosomal subunits. And again, as we talked about, when that occurs, we are interfering with that ribosomal apparatus. And of course, when that happens, you can't interpret genetic codes, you can't create a cell wall, and you get killing of the bacteria. So keep that in mind. Concentration dependent, though. We talked about aminoglycosides. So now we usually give a bigger initial dose versus intermittent dosing, because this is what defines the killing principle, is how high this peak is. And we usually do 7 milligrams per kilogram for gentamicin or tobramycin for gram negatives. For gram-positive synergy for streptococcal species, typically in the setting of infective endocarditis, we do a 1 milligram per kilogram every 8. In certain situations, we can do 3 mg per kg daily. But this is the schematic. Again, the concentration. When you give the dose, you can see 2 dosing schemes, the traditional versus the extended interval. This would be the traditional right here that you see in orange. And we would draw a peak and we would draw a trough. For the most part, we want our trough to be less than 2 is what we want. If it's gentamicin and we're doing synergy dosing, we want the trough to be less than 1. If it's gentamicin, we want our peak to be between 3 and 4 for synergy dosing, for gram-positive synergy dosing. And when we do a peak for tobramycin full dosing, depending on the severity of an infection, but it can be anywhere from actually 6 to 10. It just depends. We'll just call 8. And then again, you want your trough to be less than, it's the wrong one. You want your trough, let's pretend like this was this is the tobramycin. If this was the peak, you'd want it to be 6 to 10, and you'd want your trough again to be less than 2. Now, this is the high dose. This is going to be a 7 milligram per kilogram dose. Usually it's based off of ideal body weight. If they're more than 1.2, their ideal body weight, their actual weight, you can use adjusted. But you give 7 mg per kg because you want this very, very high peak. And then you slowly let it get excreted over, and it depends. This may be a Q24-hour interval. a Q36, a Q48. But what happens is you get to this drug-free zone. Now, remember, even though you're less than the MIC with aminoglycosides, remember we talked about this, they have a post-antibiotic effect. So you're still getting cellular kill, even though you may have undetectable levels. But the two dosing schematics are going to be the full dose with the tobramycin or synergy dosing with the gentamicin. So something to keep in mind when you think about the pharmacodynamic killing potential of aminoglycosides. Now, this level, this could be anywhere from 18 to 30. You're thinking, man, that's awful high. But we know you don't get, it's not more efficacious than traditional dosing versus extended interval. But what the premise of it is and what they've shown is you have decreased nephrotoxicity. So that's the reason behind it. And then the synergy, I told you about synergy with MRSA. Kind of got rid of that with gentamicin. Well, we did get rid of it because it wasn't proven to be a benefit to the patient. It only increased the risk of acute kidney injury associated with aminoglycoside administration. And then the enterococcus, instead of ampicillin gentamicin and synergy, we're doing ampicillin ceftriaxone, much safer. So the strategies with traditional dosing, certainly it's going to be multiple lower doses per day. And when we use it is when we're unable to safely use an extended interval. In this case, again, we're going to get peaks and troughs, which I define. Now, you have to do therapeutic drug monitoring because aminoglycosides have narrow therapeutic indexes. With the extended interval, it's usually larger doses, somewhere around the 7 to 8. Depends. If it's cystic fibrosis, we'll go high as 12 to 14 milligrams per kilogram. But in general, it's a 7 milligram per kilogram dose for the tobramycin. And it's usually every 24 hours, not every 12. You'd have to have some really, really good kidney function to every 12. But we're maximizing those pharmacodynamic principles, knowing that it's a concentration-dependent killer. So the higher that concentration, the more kill we give. And then we have a drug-free interval where we can take advantage of the post-antibiotic effect. So you see how we're getting a benefit here with no detectable drug concentrations, which means less nephrotoxicity. So we're relying on that post-antibiotic effect big time to help us in the drug-free interval, but we're going to end up with less nephrotoxicity and associated ototoxicity. And we don't have to get a peak and a trough. What we'll do 12 hours after the dose, we'll get a random level. And we put that into a nomogram known as the Hartford nomogram, which was created by a gentleman, Dr. David Nicolai. He's a colleague of mine that I've been able to do some local research with. But when you dose aminoglycosides, first thing you need to do, you need to understand the principles behind it. But a pharmacist is going to take this over for you. And that's what you're going to do, is you're going to just consult pharmacy to dose aminoglycoside. But you got to determine the indication for the aminoglycoside, because that's going to determine your dose. So urinary tract infection, there's no reason to get overly aggressive. If it's synergy for Enterococcus faecalis, we're just going to do low dose 1 mg per kg gent. So we have to know. And at that point, you can decide, can I do a high dose extended interval, or do I need to do traditional dosing? And for the gram negatives, for the most part, unless there's underlying profound kidney injury, we're going extended interval. But that's why you calculate the patient's creatinine clearance. But then you need to identify the patient's weight. And what I do is I will use the patient's actual weight. Unless they're 120% of their ideal body weight, then I will do adjusted. It has a low volume of distribution, so you don't have to necessarily account for adipose tissue. If you work at an institution that 100% does ideal body weight, that's not wrong. There's literature to support it either way. What you don't do is, when you are obese, you don't use actual body weight, because you can substantially overdose the patient. Remember, if you're dosing adipose tissue, the drug doesn't distribute highly. I think the volume of distribution is around 0.2 or 0.3 from a populous perspective, where Vanco is 0.7, 0.8. But you're going to calculate your dosing and your frequency, and then you need to decide, do you need peaks and trough? If what are those peak and trough targets? Or do you just need a random level because you're doing the extended interval dosing? So that's what you need to decide. And this gives you an idea on traditional dosing. For example, Tobramycin, depending on the indication, is going to be 1.1 to 2.5 milligrams per kilogram per dose. Every 8 hours, if your kidney's intact, if you have some underlying level of renal insufficiency, but not profound, we're going Q12, and we're checking peak and troughs with traditional dosing. 20 to 39, more severe renal dysfunction, we're going Q24. Less than 20, you're going to give a dose, then draw a level. Amikacin, for the most part, is just double the dose, and you get it. But this would be your traditional weight-based dosing. And then I put down here what to use. A lot of people will use ideal body weight, and that is not wrong. I've just elected to use actual weight. Actual weight, if so, use actual weight if less than ideal body weight. Traditional dosing, use actual weight. I use adjusted if you're greater than 100%. That's what I do. Otherwise, I will use actual if you're less than 100%. And it's worked out fine. Remember, I'm drawing levels. So I have an idea. I have a clue what's going on. And so I don't really, but what you don't want to do is the obese patient, you don't want to use actual weight, because then you're going to end up dosing a lot of adipose tissue, and that can lead to some pretty profound sequelae. So with traditional dosing, remember, we're going to monitor peaks for efficacy, because remember, the higher the peak, the more efficacious or killing in the troughs is going to be to monitor for that nephrotoxicity. So when you have high troughs with prolonged therapy and you throw an increase in age and other nephrotoxic agents in addition to that, you really increase your risk of nephrotoxicity. So when you think of nephrotoxicity, that's related to troughs. That's why when we do traditional dosing, we want the trough to be less than 2. When we're doing synergistic dosing with gentamicin, we like our trough to be less than 1. So that's very important to know. Now, when it comes to an irreversible ototoxicity, this is going to be associated with higher peaks. Now, I know what you're thinking. You're going, but you're giving these huge doses with the extended interval dosing and getting high peaks. Yes, but because you have a sustained drug-free interval, we don't really appreciate that. So that's something to keep in mind. But for traditional dosing, we usually, I'm going to actually say it depends. If it's a UTI, it's going to be 5. If you have a raging Pseudomonas infection in the lung and you're using this in synergy with Zosyn or meropenem or cefepime, whatever it may be, it can be anywhere from 5 to 10. It just at least 8. But again, you're not going to be given another dose until you get that trough at least less than 2. But this is very important to understand what relates to the toxicity. Ototoxicity, I want you to think of peaks and nephrotoxicity troughs. And that's why in dialysis patients, I always give my dose before dialysis, and I can explain why. I've had a lot of arguments with that, but people think I pull stuff out of midair, and I don't. It's based on literature. And sometimes what I like to tell people when they try to argue with me about it, it's like, well, what have you read? And I'm all for a good debate. But again, it's like, are you saying this off an assumption, or have you read something? But anyway, I like to give the drug, if it's a dialysis patient, I'll get a level before dialysis, and then based on what it is, I'll calculate my dose that I need, and I'll give it before dialysis, and I'll get that peak, right? I'll get that peak, and it's they're not excreting it, so you're following here. And so let's say this is 9 a.m. to 10 a.m. It's up here. They have dialysis, and it knocks it back down to maybe here. So, but here's what happens when you give these big doses after dialysis. You have dialysis, you knock it down some because you do dialysis, and dialysis is going to pull anywhere from 30 to up to 50%. These high flux polysulfone filters that are used in hemodialysis are extremely efficient. So I give my dose after dialysis and I get this huge peak. Well, now it's running up high. And I'm not worried about nephrotoxicity. That doesn't matter to me. They're end-stage renal disease dependent on dialysis, so the kidneys are shot. I am worried about ototoxicity, but when I give it after dialysis, I have this. Remember, I got my peak kill. I'm gonna have my post-antibiotic effect. It's not like there's not any in the body, but I mitigate the risk of ototoxicity. So tell me where I'm wrong. It's like, okay, Greg, that sounds good in principle. Has it been proven? The answer is yes. That's the protocols that I developed. Do not come out of thin air. They're based on updated nomograms based on literature. And that's what you get. But there's still, it just depends where you go to practice. Some hospitals will still give it after dialysis, and that's fine. If that's their protocol and that's the way they do it, that's okay too. But I just want you to know when I see it, when I teach it, it may be different than other hospitals. And you all, when you get out of PA school, whether it's the residents watching this or even the pharmacists at United Regional who watch this, you go to other hospitals and you may see other processes, and there's nothing wrong with it, but just make sure that someone can give you the why they do it. That's the main thing I get at when you do get pushback from this, is the why is, well, I just don't think it's right. So, well, I do it because I'm trying to protect their ears, but I'm maximizing the pharmacodynamic principles. If this was a beta lactam, I would definitely give it after dialysis. I would never give it before. I'd give it after. I want to get it up there and keep it up there, right? Let it roll, because I don't have a post-antibiotic effect that's really appreciable. And so that's what I want to do. So I hope that makes sense. But the aminoglycoside, oh, here we go. A nice chart on what are your targets. If it's life-threatening infections, deep-seated ammonias, you're going to want a peak of 8 to 10. It's probably going to be a little bit higher. Well, it's the same for cystic fibrosis. You're just going to need a higher dose. I'm sorry. The peak and troughs are the same. They have very, very, very high creatinine clearances. And then if it's amikacin, it's just going to be 25 to 35. Serious infections in general were more 6 to 8. And then UTIs, just 4 to 6. And endocarditis synergy, this is going to be with gentamicin. There you go, right there. But I always, on my troughs, they're 0.5 to 2. I like to target 1, and I'll base my pharmacokinetic adjustments based off that. And what I use, I do dose, the D equals dose, and then I just do population kinetics. So a volume of distribution, I just call it 0.3. And I multiply that by the dosing weight. So let's call this DW. And then I multiply all that by my desired peak, or whatever it may be. Let's say my desired is 8 and my current is 1. This kind of helps me give a dose I need. And let's say the dosing weight is 60 kilograms. You know that 7 minus 8 minus 1 is 7. Times 60 kilograms times 0.3. That didn't come out right. So 0.3 times the dosing weight, let's just say 70, right? And then times 7 comes out to 147. So if this was a dialysis patient, I'd give them probably 150 milligrams. If it was tobramycin for gram-negative synergy, I'd give 150 milligrams to get my peak of 8. And then it's not going to go anywhere. There's no elimination, because it's based on the GFR. I get my dialysis, I knock it back down there, and it's going to sit there until before the next dialysis session. Then I draw it, and let's say my level's 4. Okay, I want to target 8. So again, you can see how we can do this. And you get to a certain point, you're like, I need to hold it. Usually if it's greater than the trough you want, I'll hold the dose. But let's just, for example, pretend like we did that. And it was a dialysis patient. Again, I'm going to do 0.3 times the dosing weight of 70 kilograms times this case, 8, my desired peak, minus my reported, which is going to be 8. So it's going to be times 4. That's only going to be 84. I know that it comes in pre-mixed bags of 80 milligrams. I'm only giving 80 milligrams to get back up to there. Then I get my dialysis and I knock it back down again. And you get to a point where I'm not even having to draw levels. So you can see how that can be beneficial if you understand pharmacokinetic principles. Now, for those of you that are listening to this that are my pharmacist friends or students or pharmacy residents, you need to appreciate what I just said. The PA students, just understand that that's kind of what's going on when you ask a pharmacist to dose this for you. They're typically thinking along those lines. Very simplistic. These formulas can get pretty complicated. Pharmacokinetics has always baffled me, because I always jokingly say, if you need a PhD to dose a drug, just find another drug. But anyway, you get my point. But so anyway, your options with your peak and troughs, usually we'll get a peak after the 3rd dose, right? 30 minutes after a 30-minute infusion, and then we'll get a trough before the 4th dose. So this is what I like to do. And the reason I do that, because notice it's in the same interval. But some will get a trough 30 minutes before the 4th dose and then get their peak after the 4th dose. That's okay, but you're in 2 different dosing intervals. So you do, to a certain extent, have to make an assumption. So I'm going to tell you right now that I'm going to recommend option 1, but is option 2 wrong? Absolutely not. The reason they like this is because it's around, what they'll do is peak and trough around the 4th dose. So it's more like this. In a 2-hour period, you get what you want, versus this and this over an 8 to 12-hour period, if that makes sense. So dosage adjustments, if you're not at the goals you've established, again, use those kinetic principles with the parameters you're giving, to come up with your subsequent dosing, your follow-up dosing regimen. So if the peak and trough are both low, you want to proportionally increase both. So decrease the interval, increase the dose, right? If your peak and trough are both high, decrease the dose and increase the interval length from Q8 to Q12. So just keep that in mind. But again, this is why you'll dose pharmacy. You'll ask pharmacy to dose this for you. You need to know the concepts, and you need to know how to do it so you can appreciate what is going on. But the reason, it's not that you can, as a PA or a physician or whatever, a nurse, it's not that you can't dose it, it's just it takes time. And when you got 30 patients to see, hey, the pharmacist is going to be on the floor all day, I'll just ask them to do it for you. They'll know what to do. They'll take care of it. And that's one less thing. There's going to be protocols, so you're protected. It's not just, hey, we're going to do that. There are collaborative practice things put in place per the Pharmacy and Therapeutics Committee that covers you in case the pharmacist has a misadventure of some sort. But so the extended interval, again, this is where you're giving the higher dose, and usually about hour 12, we'll get a random level, and this is somewhere around here or here. 8 to 12 is when I do it, but then we plug it into the Hartford nomogram. Again, that was created by David Nicolai. The reason we do it, it's not more efficacious, but you can give larger doses less frequently, and you're taking advantage of its concentration-dependent killing. And then, well, you're going to have a time when there's no antibiotic detected in the blood. That's okay. We have the post-antibiotic effect that we discussed back with lecture 1. But the advantage is it's at least efficacious, but there's less nephrotoxicity and ototoxicity. This was the main reason. Extremely convenient and very easy to calculate. And to a certain degree, it can cut your cost some. So it's not a bad situation. It's not a bad opportunity. It's not a bad schematic or plan for dosing. So something to keep in mind. Now, when we typically avoid the extended interval dosing, no doubt if someone is on dialysis or just a creatinine clearance less than 30, we typically avoid it because that peak, it's not going to clear fast enough. I think the Hartford nomogram extends from Q18 to 24 to 36 to 48 hours. Anything beyond that, though, you need to go to more traditional pulse dosing. If a patient has burns greater than 20% of the body, no doubt there's a lot of weeping going on. There's a lot of changes in distribution. Cirrhosis and ascites, again, volume changes and distribution changes in pregnancy. Although in pregnancy, we will do gentamicin 5 mg per kg. We will do the extended interval in that. So when I say pregnancy, that's not necessarily a no-no, if you will. So very good. And I didn't know that was popped in there. I forgot about that. But there's an example of ascites. A lot of distribution can come into the fluid, and that changes a lot of things when it comes to drug dosing, especially in the setting of like hepatorenal syndrome. There's no intravascular volume because you can see here it's all in the peritoneal cavity. And there's some nice stuff. ACCP would have been April 2023. Their newsletter had a nice pro and con for giving albumin for cirrhosis and ascites, etc. So pretty interesting read. Those are always fun. But how would you do it? Just FYI, the extended interval, it's going to be a 5 to 7 mg. With tobramycin, we're pretty much always doing 7. If it's gentamicin in a pregnant woman, we're typically doing 5. It just depends what protocol you look at. But you can look at the intervals, but it really doesn't matter. We're giving the dose, and 12 hours later, we're giving a level. Then we can establish our dosing interval based on, and I think it should be over here. There it is right there. We'll get there shortly. But actually, let's jump to it now. So when I give that 7 mg per kg dose, we're going to give it, and you're going to see whatever it goes up to. And it could go as high as even 1420. but it's going to start to trend down. And so let's just pretend like this is the trend line right here. And I get my level at hour 10, let's just say. So at hour 10, we're right there. So this would actually be a Q36 to Q48 hour. So let's say I get my level at 11 hours, and this isn't a straight line. This is just for example. It would not look like this, but I'm just drawing, just for example. Let's say 11 hours after the dose, I got a level, and you can see there, and the level was 3. I'm just making stuff up. These lines do not, they are not to scale. So, because you can see that would not be Q36, but you can see there, if your level was 3, you would be a Q, everything under this would be Q24 hour. If my level at hour 11 was 9, you can see there, I'm going to go to pulse dosing. So you can see, but that's how the Hartford nomogram works. You just get your level, however many hours after the dose, and you plug it in. So let's say you get it 13 hours and your level's 2. If I ask you the question, what would your dosing interval be? You would say Q24. If it was 3.5, you'd be in the Q36 interval. So ignore this line I drew, but I hope that makes sense. Okay. But again, I dose it the same. Some will use ideal body weight all the way across the board. I do the actual body weight, regardless of it is, so long as it's less than 120% of ideal body weight. If it's greater than that, I use adjusted body weight. And again, I'm drawing levels, but again, you're going to get that random level, at least 10 hours after the dose, after the first dose, and then use that nomogram to assist in your interval selection. And then there's the Urban and Craig nomogram. If you're doing, this was based on the 5 mg per kg dosing. And I think a lot of people have a lot of mistakes. They will use the gentamicin, but they'll plug it into the Hartford once daily. The ODA stands for once daily aminoglycoside, what we call extended interval now. But if you're doing the 5 milligram that we see with gentamicin, especially in pregnant women, you really need to plug it in to the Urban Craig nomogram because they don't have a Q12 hour option. So that's probably a little pearl to keep in mind. The ADME, they're highly protein bound, so they don't distribute in fatty tissues. So that's why we dose it either ideal or adjusted if you desire. Then renally eliminated, big time. This is a GFR dependent drug. You do have to adjust based on renal function and the interactions, other nephrotoxic agents for sure. Some of the pearls we monitor for the nephrotoxicity, the ototoxicity that you have. If you dose it right, you mitigate the risk of deafness, which if it does occur can be irreversible. It is an effect on that 8th cranial nerve. So that's the thing. Could you use gentamicin or tobramycin eye drops in the ear, maybe for otitis externa? And the answer is you could, so long as you don't have a perfect tympanic membrane, your eardrum, so to speak, isn't perforated, because then you're going to have drug get back in there with the vestibular and issues around that. And then that itself, that's going to be a very high concentration. So just keep that in mind. If you have that otitis externa, you have that earache, it's okay as long as that tympanic membrane is not ruptured. If it is, do not give aminoglycosides, otic, in the ear, please. So the risk of neuromuscular paralysis, so very high doses, this is not as much as an issue because we don't do paralysis as near maybe 90% decrease, maybe more, maybe 95% decrease compared to the 90s and early 2000s of neuromuscular blockades. And that was important because we used aminoglycosides all the time back then in synergy with Zosyn or other anti-pseudomonal antibiotics. But you do get some neuromuscular junction issues with acetylcholinesterase and acetylcholine, and you can get paralysis when given concurrently with neuromuscular blockers or when high doses aren't administered too quickly. So that's more of a pearl. I've never seen this before. All the patients who are on neuromuscular blockers, they're usually on mechanical ventilation, you hope, right? So you're not going to get that. So I've never seen it, though, when it's been given just by itself to a patient who's not on ventilation support. I've never seen that occur, but it can cause paralysis. So I think you certainly need to appreciate that. But if in my case, the patients back in the day when we used it in the ICU, they were typically on mechanical ventilation. And back then we hadn't really adopted the high dose. We were doing traditional dosing. So it really wasn't an issue or concern. And when the airway's protected and they have ETT tube, they're intubated, if you will. Okay. So I don't really, it could though deepen the level of paralysis. So if you're doing a train of 4, where it gives electric shock on their temporal nerve or their ulnar nerve, you give 4 shocks and you get 2 twitches. It may make it where you give 4 shocks and you get no twitches. That'd be an extremely deep level of paralysis. And that in and of itself can have some issues when it comes to muscle breakdown, especially if it's given in the setting of steroids. So something to keep in mind. So that leaves the 30S subunit drugs. Now we go to the 50 S subunit, ribosomal subunit drugs. Now remember clean tag. So we talked about the tag part, the 30S, tetracyclines and aminoglycosides. Now we're going to talk about the clean. And the clean is going to be clindamycin. The L is going to be linezolid. That's not on there, but linezolid, the 50Ss. The E is going to be erythromycin, which is the macrolides and the azolides. Then streptograms and chloramphenicol. So that clean tag is a good way of the home plate, is a good way to remember them. 50 up here, if the thick part of the plate is going to be wider, so a bigger number. 30 down here and clean tag. If you remember that, you'll never forget these. Now remember, when I talk about macrolides, that also includes azolides, and that's going to be your erythromycin, which is back up by accident, and your azithromycin, which is your Zithromax, your Z-Pack. Oh, and I said linezolid, it wasn't there. A linezolid is an oxazolindiones. So that is linezolid, or brand name Zyvox. I'm sorry, I didn't even see that there. That's the class it's in. There is another class in there, and I just went tadazolid. I can't think of its brand name. There's linezolid and there's tadazolid. Tadazolid is probably maybe safer, but it's only because they didn't use it as long. So I don't think it had time to have some of the side effects that you see when you use it beyond 7 to 10 days, which aren't bad anyway. So, but let's start out with these macrolides. Now, remember, if you want to get technical, clarithromycin and azithromycin are azolides, but just keep that in mind. But macrolides, first thing I want to say, in this is Zithromax, jack of all trades, master of none. Gosh, when I think of erythromycin, you know what I think of? Using it for GI motility in a baby in the NICU. That's what I think about for 2 or 3 days. I don't think of it as an antibiotic because it mimics motilin. When I think of azithromycin, I think of providers prescribing something just to appease the patient. It doesn't cover pneumococcus very well anymore. A lot of resistance. It doesn't cover group A strep anymore. It's very good for some atypicals. It can be used in conjunction with some mycobacterium species, but there's not necessarily a place for these drugs anymore. So it's something to appreciate and keep in mind. STDs, you'll see it in combination to cover chlamydia, gonococcal infections. So it'll be given, if you don't know what it is, you'll give it in combination, usually with 1 gram Rosepin IM and 1 gram of azithromycin oral. But mycobacterium avian complex, some of your opportunistic infections, no doubt, I think that it's good. But as far as your actual treating of something, it doesn't have widespread use, but we see Z-Pack orders all the time. I think if you have a patient with acute exacerbation of COPD, you look at the literature, it doesn't really matter what antibiotic, just give an antibiotic. And I think the Z-Pack's good because you do get some anti-inflammatory activity from azithromycin. And that was one of the premises with COVID. They were given it not necessarily for antibacterial properties, but an anti-inflammatory component. The literature's out there, no doubt, to support it. The only problem they found, it'll decrease exacerbations of COPD when you give it continuously 250 daily, but there was an increased risk of deafness, so that's a problem. But at spectrum activity, you're going to get some gram-positive. You can't rely on it, though, for Streptococcus pneumococcus, and you can't really rely on it for group A strep, so we've lost that. Some gram-negative activity, I wouldn't trust it. You do get your atypicals, such as your mycoplasma, your chlamydia pneumonia, and your Legionella pneumophilia. It will cover those. You do get some mycobacterium coverage out of it, so you'll see it Mycobacterium avium complex prophylaxis in those with CD4 counts, I believe less than 100, less than 200 is more your PCP. It may be less than 50 for MAC, but you start getting cryptococcus and stuff going on. And then some spirochetes, but you're not going to get any staphylococcus. I wouldn't even trust it for Staph aureus. So no staph coverage, no enterococcal coverage. I wouldn't trust it for any gram-neg or positives anymore. No pseudomonal coverage, no Bacteroides coverage, no anaerobic coverage, that is. So again, jack of all trades, master of none. If someone's demanding an antibiotic and you know it's viral bronchitis and you can't get them out of the office, then, by all means, Z-Pack. Best thing is just tell them, no, there's no good medicine. But when it was beneficial, respiratory tract infections, now certainly it's a part of the CAP guidelines, depending how you read them. Do you add atypical coverage? So if you have a patient admitted to the hospital, it does cover atypical. So you're going to see a combination of ceftriaxone plus azithromycin. The azithromycin is for the atypical, so the mycoplasma, the chlamydia, pneumonia, and the Legionella pneumophilia. Now, if you have Legionella, there's some stomach, some abdominal things that go on. There's an associated hyponatremia. Legionella isn't something that just pops up in the community. It's usually revolving around dirty water cooling towers or something along that line, and there's an outbreak. But respiratory tract infections, yeah, CAP is what I'm thinking about to cover atypicals. But chlamydia in your MAC, your Mycobacterium avium complex, and that's given with other agents. And then in some cases, pelvic inflammatory disease. I know they do give it to pregnant women sometimes for group B strep, Streptococcus algalactia, but they also give other drugs with that as well. It's not just Zithromax, and just that's what they're doing with that, though. But here's your coverage. We've lost this. This is as high as 50% resistance. This is as well. And for Haemophilus, I think we have better options. So it's kind of a route. I don't know if it was destroyed. We induced the resistance of the drug with everybody getting a Z-Pack, a Z-Pack this, Z-Pack that. Yeah, I went to the doc today. I was sick. What'd they give you a Z-Pack? Did you feel better? Yeah. Well, they go on day 10, and they were going to get better, start getting better on day 11, 12 anyway. But, the Z-Pack cured me. And Z-Pack. The same thing happened with levofloxacin and the quinolones. We had this nice once daily quinolone that we were given for just simple cystitis. And in some cases, asymptomatic bacteria. There was no cystitis. Something to think about. But how do these work? They irreversibly bind the 50S ribosomal subunits, and that's going to inhibit, again, that translocation of protein synthesis. And you can see here, when we talked about our 30S, we were right there. Now we're just taking it up here, inhibiting translocation. And they're generally considered bacterial static, but my opinion on static versus cidal, the 3-log kill. And how do you remember static? Country music television, right? Clindamycin, macrolides, and tetracyclines. Remember? Okay, GI. Absorption can be altered depending on the formulation. Azithromycin, of course, has a very long half-life due to its accumulation in tissue, so it has a large volume of distribution. So we typically, you can actually do, instead of doing 500 on day 1 and 250 for the next 4 days, 5 days total, some hospitals will do 500 times 3 days. Some outpatient providers will write for 500 times 3 days. I think what you get into is you increase your risk of maybe some GI intolerances when you do that. But it's something to keep in mind. Drug interactions, that's going to be more along the lines with erythromycin and clarithromycin. Azithromycin, for the most part, is pretty clean. Now, it did get some bad press about QT prolongation, but while all of these can create that, especially clarithromycin, azithromycin is going to be the least likely one, but never say never. But I don't really consider it a rabid QT prolongation drug. But just know that that risk and that opportunity is always, even if it's a small risk, it's a risk nonetheless. So keep that in mind. And then again, the GI disturbances are the most common adverse effect. And you're going to see that more with erythromycin Because remember, it mimics motilin, but you can also see that with the others. Clarithromycin is weird. I've taken it before, and it leaves I'm going to call it a metallic taste in my mouth. So just something to think about, something to appreciate. But I think you do have to really look at the drug interactions, and then especially with the erythromycin and clarithromycin, you got to appreciate the QT prolonging risk, especially with other drugs. Now, fluoroquinolones we'll talk about, really ciprofloxacin, there's not much. The only one we have on the market now that really concerns me is moxifloxacin. That doesn't concern me, but in relation to QT interval prolongation, that's the only one that really has an effect. It's not really a class effect, but ophthalmic use, we will give erythromycin for prophylaxis of ophthalmia. Then the torum, that is to prevent Neisseria gonorrhea and chlamydia trachomatis. That is the #1 leading cause of blindness in newborns in some places. So I think it's a state law. Every baby that's born will get erythromycin or some type of macrolide eye ointment placed on their eye. That's every baby, every time. Common uses, though, we use it in CAP, specifically to cover atypicals and acute exacerbation of COPD. Yeah, you get an antibacterial component of it, but a lot of it is the anti-inflammatory perspective. Those opportunistic infections, prophylaxis specifically, like for MAC, STDs, we talked about that. And then your whooping cough. If you're not familiar with whooping cough, you need to look it up and understand what is the bug that covers it. I would tell you, but I want you to look up something. So Zyvox, we're going to jump to Zyvox, drug I like. These we have 2 of them now, and Cevextro, that's the brand name for Tadalafil. So Zyvox came out initially, the brand name or the generic is linezolid. It's in PO and IV. 1-to-1, if you're going from IV to PO, 600 milligrams IV, 600 milligrams PO. The Tadalafil, again, IV to PO, nice 1-to-1 mix. Now, this has a very, very nice spectrum of activity, including methicillin-resistant Staph aureus. Now, yes, this is a bacterial static agent, but remember, it barely missed the log 3 kill at 24 hours. Barely missed it. Boom. That was 24 hours right there. It barely missed it. So, yes, it's considered static, but it plays more like a cytal. But this is nice because it's actually effective against vancomycin-resistant enterococcus. Now, remember, that's usually going to be Enterococcus faecium. And then another one is Mycobacterium tuberculosis. And where do we use it? I got to talk to some patients in Cajado, Africa that were on it. It's long-term. It's for your extremely drug-resistant tuberculosis. And talking to their ID people there, the thing, Joseph Sancook is his name. The question I had for Joseph is, do you see any signs of optic neuritis? And absolutely they do with long-term use. And they do eye exams every week, but they don't really have a lot of problems. They check every week, but thrombocytopenia hasn't been a problem. It's quickly reversible, and they re-challenge, and they don't have a lot of issues with neuropathies. They do give all their patients B6 with it, because that's anecdotally potentially decreases the risk of neuropathies. But what do we use these for? These are going to be your deep-seated MRSA infections. Yes, you can use it for MRSA bacteremia. It is an option. Some will argue you can't, but there are studies that show it's not necessarily first-line therapy, but it's something that we do. So depending on the situation, we would use Dapto or Vanco before we would go that. But if you start having failures, it's no doubt something you could use. But also vancomycin-resistant enterococci. Those are going to be your 2 big ones that you're going to see it used under. And Tadalafil is the same, but you can see Tadalafil, linezolid, boom, VRE, Enterococcus faecium, fecalis, you could, but there's other options for that, specifically ampicillin. Pneumococcus you're going to cover, strep pyogenes you're going to cover, but for these you have more directed therapy. Save your linezolid for stuff like MRSA when you run out of options, or VRE. But very nice drug, and it comes in IV and PO. Now this is going to work on those 50S subunits, so binds the 23S ribosomal RNA of the 50S subunit. to block the formation of that 70S initiation complex. So again, bacterial static, but bactericidal against Streptococcus species. But this is very, you know, I've said what I thought on that. It barely missed the cutoff to be a cidal drug. So that's why when someone says, oh, you can't do static drugs, yeah, okay, let's talk about that. You can. I don't distinguish the two. And as I've said in previous lectures along infectious diseases, if you want me to send you the article that supports that, I certainly will, because it's very nicely done. But administration, what we like about this, very good looking profile, 100% bioavailable. So you don't have to use IV. You have the opportunity to go from an IV to PO and still have the same biologically available drug. No renal or hepatic adjustments are required. There are some drug-food interactions. Now, linezolid and tadalafil, they are very weak inhibitors of monoamine oxidase, but there's a potential for serotonin syndrome if you take it with tyramine-containing foods, very rare, and agents that are SSRIs or SNRIs. Now, the initial recommendation was if you're on an SSRI or SNRI, you can't take Zyvox. Most of us don't buy into that. You monitor your patient, but I know the case reports are out there, but it's very rare. And if the patient needs it, it's not a reason to hold it. The initial package insert said crazy stuff like have a 2-week washout. Well, what if you have a life-threatening MRSA or VRE infection now? I'm not waiting 2 weeks. If you want to DC your antidepressant while they're on Zyvox, that is fine. Or find another alternative. But if that's all you have and your reason for not giving it's because they're on an SSRI, that's not a valid reason. And there's more and more literature that supports the concurrent use. But when it first came out, we would try to get stuff DC'd and held. But as time has gone on, the inhibition of monoamine oxidase is very, very weak. But you still need to appreciate, while it's weak, the risk is still higher than none at all if it's a tyramine-containing food, those cheeses or wines, whatever, or someone who's taking a serotonergic drug. So in monoamine oxidase inhibitor drugs, we don't see as much anymore, thank goodness. But you need to appreciate what serotonin syndrome is. Think of excitation, if you will. Clinical pearls, you can have some GI upset, which can include nausea and up to diarrhea, not a lot of vomiting. Headache and rash are not common, but not uncommon. The myelosuppression is probably the big one. It usually presents itself in the form of thrombocytopenia. Typically, that's after an extended duration defined as greater than 2 weeks. So if it's a week to 10 days, you know, you're going to check maybe a one-time CBC, but just know it's reversible, but you're going to monitor that CBC during prolonged courses. But it usually takes greater than 14 days in order for that to happen. So keep that in mind. So maybe if a patient has pre-existing myelosuppression, you avoid it. But I'm going to tell you, if it's the only thing they have to treat that infection and it's life-threatening, we can worry about this later. So when you use it beyond 28 days, and where this comes into play, we've used it in other countries, Africa specifically, for osteomyelitis for 6 to 10 to 12 weeks, for infective endocarditis for 4 to 6 weeks or longer, for extremely drug-resistant TB for months. And you do have to appreciate the risk of optic neuropathy. The peripheral neuropathies occur, but this is the one that can lead to irreversible blindness. So you have to be cognitive of that. Now, what do? They do eye exams. They look for it. But the peripheral neuropathies, again, there's anecdotal evidence that if you give B6, you can mitigate those peripheral neuropathies. But you'll hear people, if they take it long-term, have those issues. So moving on to the laicosamides, this is going to be clindamycin. This is Cleocin. This comes in topical. This comes in PO and IV. Its spectrum of activity is the aerobic gram-positive bacteria. It does have MRSA coverage. It's not 100%, but it's not bad. It does have some anaerobes. So the typical saying is is clindamycin above the belt and metronidazole below the belt. So that's something to keep in mind as you do these. So, but gram-positive bacteria, yeah, you get not very good pneumococcus. No, I wouldn't trust it for pneumococcus at all. I wouldn't trust it for group A strep at all. For staph, yeah, you could trust it, I think, for the most part, but you're not going to get any real gram-negative, no gram-negative coverage. You're certainly not going to get enterococcus. So, it's just not, or atypicals, it's not a drug we use. Where I see it deployed the most, it's in the form of the 900 milligram dose when someone has a pretty profound skin structure infection. We're not using it to kill the bacteria, we're using it to bind toxins. And I don't know if I mentioned, but your two big ones. So with Staph aureus, there's a community acquired type 4 Staph aureus. There's 4 wild type strains, so 1 through 4. But the 4 is typically community acquired, a little bit larger in size compared to the others, oddly enough. But it's encoded. Some of those are encoded for what we call PVL or Pantone Valentine leukocidin, and that's a super antigen, meaning you get a super response from your immune system that can lead to hemorrhagic issues and all kinds of things, and septic shock and death. And but it is toxic shock syndrome. It's staphylococcal toxic shock syndrome. And with some of your streptococcal species, like group A strep, you can see the same thing. And those are encoded for M protein, and you can get a streptococcal toxic shock syndrome. Well, clindamycin and linezolid, by the way, as well. I didn't mention that. Linezolid is a toxin binder as well. So that's something to appreciate and go with. So keep that in mind. So we can do that. We can give Clinda for that. It's not unheard of. I've seen a couple of cases. One was fatal of a staphylococcal toxic shock syndrome. I won't go into the details. It was a young fella. And as soon as he was given vancomycin and they started lysing those bacteria, it was instant. It's like he just dilated and there was no coming back, but it was all sent off to the state labs. And it turned out it was a PVL producing strain, unfortunately. But you'll see it used for skin, soft tissue infections sometimes. Respiratory tract infections, not really, but sometimes for acne, more on the topical presence, if you will. But here's its spectrum. I wouldn't trust it for pneumococcus. I wouldn't trust it for group A strep. I wouldn't trust it for Bacteroides. For staph, MSSA, you could trust it. We have better, safer options. For MRSA, you could trust it if you have a culture sensitivity, because sometimes it is between 80 and 90%. And so you do have a risk of therapeutic failure. So the clindamycin mechanism of action, it has a similar mechanism of action to macrolides, some overlap. So there are concerns for cross-resistance. I don't know. I hope I have a slide that shows the D-test, but this gives you your mechanism. Again, it's static, and there it is. There's the D-test. So you can see here, there's erythromycin resistance to Staph aureus. And when you place the clindamycin, you can see on this side, the zone of inhibition. You can see here on this side, it looks great. You have a nice zone, but if you notice here, you had inducible resistance. But it makes the shape of a D. So they call this the D test. And this is just, and it's called a negative and a positive clindamycin D test. This one here is a positive D test. So if it was positive for this, you would not want to use clindamycin in a patient like this. So that's just what you're looking for. Your micro labs will take care of this for you, so nothing to worry about. But very good distribution, including the bone, but not CSF. You really wouldn't use it for a CNS infection, right? But there's this excretion, low urinary elimination, so we do not use for UTIs. No real drug interactions. Diarrhea is very common with clindamycin, and in the 80s, it was associated with a huge breakout of Clostridium difficile. So it does cause dysbiosis or disruption of your normal flora in your large bowel. So you need to appreciate that. And it's also been associated with some severe skin reactions or toxic epidermal necrolysis. So that needs to, you need something you need to be aware of. And if that does seem to be occurring, you got to discontinue the drug immediately. But I don't know the relationship now with C. diff and it's Clostridioides, by the way, now, not Clostridium. The taxonomy is different, but I don't know. My thought is this, that was back in the 80s, and we had an outbreak that was associated with quinolones, but any medication that can disrupt your normal geological large bowel flora and you're colonized with Clostridium difficile, that can lead to overgrowth. So that's just something you need to appreciate and something you need to keep in mind. So moving on to chloramphenicol, this is something you're not going to see rarely used. We'll talk about it to appreciate it. It is working on that 50S ribosomal subunit, very broad spectrum. You can look at the coverage. No pseudomonal coverage, rarely used due to its toxicity profile. We only use it if there's no other options. I just want to introduce it to you, but I don't think we really need to go into a lot of discussion with it. But you can see its mechanism. It's going to bind to where that peptidyl transferase reaction occurs. And again, the end game, and you see the 50S subunit, that's initially what we're interacting with. The end game is a bacterial static dependent action on the bacterium cell wall disruption. That's what's going on. When you look at chloramphenicol, yes, it has good distribution, a large volume of distribution. So you can see all the issues, you can read through there. You can see the potential for drug interactions, so it can block the metabolism of warfarin and phenytoin, so it can increase your INR and your propensity to bleed. It can increase your phenytoin levels and your propensity to have heart block or nystagmus and the CNS side effects that go with it. Keep that in mind. The pearls, though, the bone marrow toxicity, that is the biggest rate limiting step. And that's a US black box warning and something you're going to have to be appreciative of. We cannot use it in breastfeeding mothers or neonates because of the risk of gray baby syndrome. And then we can't use it in those with glucose 6-phosphate dehydrogenase deficiency. Hemolytic anemia will occur. So I mainly with chloramphenicol, I want you to appreciate we've used it in some ranchers before and things like that, but appreciate those clinical pearls. Centersid, real quick, it is available. I want you to know one thing. It only covers Enterococcus faecium. It does not cover faecalis. That's number one. We would never use it now. It was a big drug because it covered VRE. That's what this is. But we have so many better options now. But back in the day, this is all we had. So the first thing, though, you have to have a central line to give it because it causes a lot of infusion-related reactions. It was only effective for Enterococcus faecium. You need to know that. So no other gram-negative coverage. It would cover MRSA, but we had Vanco for that. We used it for VRE, Centersid, quinapristine, dalfapristine. It is on the market still, but there's no reason to use it. We have daptomycin for VRE. We have some of those newer generation tetracyclines for VRE. We have linezolid for VRE. We have other drugs, but its niche would be Enterococcus faecium. They can't be treated with other antibiotics. So that's what you need to appreciate with that. Now, the dalfapristine interferes with the addition of amino acids in the peptide chain, cell wall disruption. Quinapristine, similar to macrolides, resulting in complete peptide chains being released. In combination, it is bactericidal, so something to keep in mind. And but we just don't use these streptograms. And here's the pearls. It has to be administered through a central line because of the pain and inflammation it causes. I will tell you that one thing, every patient, and I've only had a handful, VRE wasn't common when this came out. It was rare. It's way more common now than it was. And there's a lot of things that can be point to that, but I want you to appreciate that these patients, when you gave it to them, and this is 50%, for me, it was everyone I asked because I would ask them in the medical, these are all medical ICU patients. None of them were intubated, but when I asked them, yes, muscle pains and arthritic type pains. And some of them, a couple of them felt like, I like to use the term, felt like they got hit by a Mack truck. That's not what they said, but that's how I described it. Maybe they said they got hit by a bus, but you can stop or reduce the dosing frequency. But this was fairly common. So it wasn't a fairly friendly drug, but when that's all you have for VRE, we were grateful to have Centersid. It played a role and it saved lives, but you probably won't ever see this. And that takes us to the end of this discussion. So let's keep moving on to the next one. And where did we go? Where were we? What were we talking about? If you see, even though this is recording, if you see something, holler at me, right? And you see how I'm putting these up there. Week 1, lecture 1, week 1, lecture 2, week 1, lecture 3. This is week 2, lecture 2 we're doing now. But we were looking at protein synthesis inhibitors. So these handouts, you're now down here to protein synthesis. You need to look at that. You need to look at your macrolide and clindamycin cheat sheet. You need to look at your tetracycline cheat sheet. DNA disruptors. Yes, let's talk about fluoroquinolones. How much time do we have left in this? I think we got a little bit of time left to get this started. I just need to make sure that I write this down, that we started the AGs and we did it. There it is. Okay. So let's keep on keeping on, as Joe Dirt would say. Let's keep on keeping on. Okay, so you know the objectives, you know what we're trying to do, and here we are. So when you think of DNA disruptors, we're thinking of, I'm starting to kind of think of maybe Bactrim, and then I'm thinking of there's your topoisomerase, if you will, and your DNA gyrase. So the fluoroquinolones are starting to come into my mind, and rifampin when we talk about RNA polymerase. But yeah, there's a lot of drugs that are going to fall in this. The big ones are going to be the quinolones. That's going to be the big ones. Certainly the sulfa drugs to an extent. Metronidazole is used often. Fidaxomicin it's an oral med, but it's not absorbed, it's topical. It is a first-line drug for Clostridioides difficile. If you use it and fail it, then you go to oral vanco. If you use oral vanco first and fail that, then you go to fidaxomicin. And then your rifamycins. And when you think of drugs like rifampin, you're probably thinking tuberculosis. And if not tuberculosis, you're thinking in conjunction with other drugs for biofilms, but we'll get there. So let's go ahead and start our discussion on the fluoroquinolone. So you can see them. Cipro was probably your big one that was around. It only covers gram negatives. Levofloxacin gives you very good pneumococcal coverage and pseudomonal coverage. So does ciprofloxacin. Moxifloxacin is nice. It's attractive because it covers anaerobes. So that makes it a nice option for maybe not so profound GI bug type infections, right? Something to keep in mind. Delafloxacin, this actually covers MRSA, and you can see their spectrums here. I would memorize this chart, by the way. You don't see Baxdela much. That's the delafloxacin. I think it has good potential because you're not really seeing all the issues with tendon rupture or tendonitis that you would see. But notice it covers your atypicals, it covers Pseudomonas aeruginosa, it covers pneumococcus, and it covers MRSA. So if you have a polymicrobial diabetic foot infection, I think this gives you an option, and we've done this before, to send the patient home on this instead of IV antibiotics. So something to keep in mind when you go through these drugs. So the big one, though, the big difference kinetically is moxifloxacin is not excreted renally. So you would never use this for a UTI. You couldn't do that. So, but you need to appreciate the spectrum of activities for these. And I think this chart is the best way to do that. So infections that we treat with fluoroquinolones, urinary tract infections, not so much now. If it's complicated, you can. For the most part, it's just respiratory infections, specifically pneumonias. You could not use moxifloxacin, though. Respiratory infections, not bronchitis, but true pneumonias. That's part of the community-acquired pneumonia protocols. I think that's fair. You would want to use a respiratory fluoroquinolones, and that's going to be levofloxacin and moxifloxacin. Those are considered respiratory quinolones. I don't really consider delafloxacin because its spectrum's too high. Now, your gastrointestinal infections, that's just going to be really moxifloxacin by itself, or you could use the others, but you would have to do it in combination with metronidazole. So keep that in mind. But for those mild intra-abdominal infections, I think Moxie is really your only true choice for that. And so if you had but even diverticulitis, they changed the guidelines. There's certain situations where you just do supportive care. You don't give antimicrobial. So I think you need to appreciate that. But let's start with ciprofloxacin. You're really not going to appreciate any gram negative. Now, you will see some situations where ciprofloxacin does have activity against MRSA, but you need to verify that on a culture and sensitivity. And when we do use it, it's usually for suppressive therapy, but no real appreciative gram-positive activity. I don't think of ciprofloxacin as a gram-positive drug. Now, if you're going to do suppressive therapy, you need to make sure that it's sensitive. Now, with all of your quinolones, it's pretty much lost its utility for E. coli. The resistance is upwards of 40 to 50%. And that's a problem, so you can't really use it empirically, and that's the #1 gram-negative pathogen out there. It does hold in the mid-70s, somewhere up to 90% sensitivity to Pseudomonas. So it certainly gives you a nice oral option for Pseudomonal infection once you get your culture and sensitivities, as does levofloxacin, as does delafloxacin. So you would never, though, use these for Streptococcus pneumoniae, not ciprofloxacin. So its utility is it's not futile, but it's certainly minimized. Levofloxacin, that's a different story. For the most part, levofloxacin, the high 90 percentile for its sensitivity towards pneumococcus. So that's why it's part of the CAP protocol. It also covers atypical. That's why you can give it by itself for community-acquired pneumonia, because it's going to cover your atypicals and pneumococcus. You would not use it for strep pyogenes. Yes, it covers it, but we have more narrow spectrum antibiotics to appreciate. The same thing that I said with Cipro is applicable to levofloxacin when it comes to staph. It's not going to be something you'd want to use empirically, no doubt, and probably not when you have definitive treatment. But if you need suppressive therapy, the potential's there. The same story with E. coli, anywhere from 40 to 50% resistance. You do get some pretty appreciable coverage of Enterobacter and Pseudomonas, so it's not a bad choice. But when I think of levofloxacin, and because of the side effects of quinolones, I really only think about community-acquired pneumonia and community-acquired pneumonia only. So, moxifloxacin, brand name Avelox. Big difference here is we just dropped the Pseudomonal coverage, but you do have your Streptococcus pneumonia coverage, and this would be a respiratory quinolone, and you have your strep pyogenes coverage. Everything else, though, is repeat what I've said for Cipro, repeat what I said for Levo. The only difference between this one and Levo is we dropped the Pseudomonas coverage, we've added Bacteroides, so this could potentially be for a minor intra-abdominal infection an alternative to other antibiotics. The problem is what is your most common gram-negative? It's E. coli, and the resistance can be as high as 40 to 50%. So you must appreciate that. You must understand that. So please, if you don't, listen to what I just said in that regard and go from there. Now, here's delafloxacin. Again, when you have a true polymicrobial diabetic foot infection, even if it includes the bone, think about this. And the reason I say it is because it gives you an oral option. As long as the patient will take it, it gives you an option. We've done that before. You do get pneumococcal coverage. You wouldn't use it. You'd probably go more in the lines of levofloxacin or moxie if you were doing a respiratory quinolone. You get strep pyogenes coverage. Again, a lot of collateral damage with quinolones. Use some amoxicillin, penicillin, Keflex. You actually do get pretty good Staph aureus coverage, both MRSA and MSSA. But remember, ciprofloxacin, when it first came out, also had very good coverage, and it developed through whether it's topoisomerase 2 or 4, DNA gyrase, it developed induced resistance very, very quick. But also notice you get the Bacteroides coverage and you get the Pseudomonas coverage. This is why we had pan-sensitive for this patient, and they had a diabetic foot. We used it, and we did it for 6 weeks. We did 1 week in the hospital IV, 5 weeks outpatient oral, and they did fine. They did very well. We got a clinical cure, but you never hear about it. I don't think it's an everyday drug, but I certainly think it's something you got to think about when you're going to send someone home, and maybe you can't get a central line or they can't get to an infusion center. This is going to give you an option, so it's something to keep in mind. Now, as far as the spectrum of activity, one way to do it, so Baxdela, you're going to get your Pseudomonas aeruginosus coverage, you're going to get your anaerobes, you're going to get your respiratory, your pneumococcus, right, and you're going to get your MRSA. But when you go from the others, the older to the newer, you're usually more gram-negative with Cipro, more gram-positive as you get up to Avelox. But Cipro is going to give you Pseudomonas. Levofloxacin in Avelox are going to be respiratory fluoroquinolones. Levo is going to give you Pseudomonas as well, but Avelox is going to give you anaerobes. Now remember with Avelox, and that's moxifloxacin, by the way, to get the names right, you're going to, you could not use that for a urinary tract infection because it's not excreted in the urine. So there is a dual mechanism of action, and usually in those cases that does create a situation of cidal instead of static. But you have inhibition of DNA gyrase, some will call this topoisomerase 2, and this promotes the breakage of the DNA strand. The topoisomerase 4 interferes with the separation of the newly replicated DNA. So you're promoting the breakage of the strand, and then you're not allowing to replicate, so you got a double whammy. For the gram-negative organisms, such as Pseudomonas aeruginosa, DNA gyrase inhibition is more helpful, more part of it. And ciprofloxacin has a very high affinity for DNA gyrase, but does not treat Streptococcus pneumoniae. When we talk about gram-positive, such as pneumococcus, this is more of a topoisomerase 4 phenomenon. Well, moxifloxacin actually has the highest affinity for topoisomerase 4, very good for treat. It's a respiratory quinolone, so very good for covering pneumococcus, but you're not going to get any pseudomonal coverage. So I think for the sake of our class, that is good to know. I don't think it's necessarily something when you're out in practice you're going to be thinking about if you're writing for moxifloxacin, but hopefully if you're listening to me, you're not going to have an overabundance of fluoroquinolone prescriptions. I hope you don't, because they cause a lot of collateral damage. But one of the beauty things about them are their bioavailability. It makes it a nice IV to PO opportunity. For pseudomonal infections or pneumococcus, it's widely distributed into the body. Remember, we talked about that exception with moxifloxacin. You could not use it for a urinary tract infection because it does not concentrate. But yeah, renally eliminated, so dose adjustments are in order unless it's moxie, and we talked about that already. You do have to worry about chelation with divalent cations, aluminum, zinc, mag, iron, calcium. It binds to them and it will decrease the absorption. Other QT prolonging agents, really at this point, only moxifloxacin is the only one that has any real appreciable prolongation of the QT interval. So that's the one you would have to have concern with if the patient was already on QT prolonging drugs. But you got to watch for those drug interactions, the cytochrome P450 system. I'm going to tell you right now, drug books might not say it, but when you give levofloxacin, which is probably the most commonly used fluoroquinolone, with warfarin, you're going to see an increase in the INR. And I've been burned one too many times. Initially, they said it doesn't interact with it, but that's not true. It does. I don't know how that statement could be made when they were detailing it, when Ortho McNeil was detailing it back in the early 2000s, but I'm going to tell you, it does. And then, of course, theophylline with ciprofloxacin, you would monitor theophylline levels. But keep an eye. Anytime you have a patient on warfarin, and you start a new drug, you're looking for drug interactions because that's a narrow therapeutic index. You don't have a lot of room for error. And if it gets too low and they throw a clot, that could cause some morbidity and mortality. If it gets too high, they could have a bleed. That could cause some morbidity and mortality. So just something to keep in mind as you go through all this. So let's see, next slide. Where are we at? We're almost to the end of this. We're almost, I don't know. I guess we're about done. Let's just finish this up though. It'll be good. Adverse drug reactions, the nausea and vomiting, diarrhea, dizziness, not as much as other antibiotics. Now, the glycemic dysregulation, hypo or hypoglycemia, I want to clarify something. While this wasn't a class effect, this was with a drug called gadifloxacin, Tequin. Gadifloxacin is no longer on the market. The phototoxicity, it varies between the drugs. Levofloxacin for sure can burn you up, but you do want to wear sunscreen, the potential for hepatotoxicity. This is a U.S. black box warning here when it comes to tendinitis and tendon rupture. What was the rate? Tendon rupture was 1 in 6,000, and in those older than 60, it was 1 in 1,600. So again, you can see why this whole list, there's been more drugs in my career removed from the market. Let's just talk about that. So let's think about it. Tequin, removed from the market for profound hypoglycemia. If it was given in conjunction with the sulfonylurea, which is a secretog for insulin, which we no longer really use. We talked about that in the spring with diabetes, but just keep in mind, that was more profound, so it was drug specific. Hepatotoxicity, that was a drug called trovafloxacin, Trovan. It was actually blowing up livers to the point of transplant. I want you to know, though, they didn't see this in the phase 3 studies. They saw this in post-marketing surveillance. So the tendinitis and tendon rupture, this is a class effect. We're not seeing it as much with delafloxacin, but it still is a U.S. black box warning. The next one, peripheral neuropathies, that's a U.S. black box warning. CNS effects, that's a U.S. black box warning. This headache and dizziness, the nausea, diarrhea, not so much. Exacerbating myasthenia gravis, it's contraindicated in a patient with myasthenia gravis. U.S. black box warning. We have an increase in C. diff infections. That's also a problem. Let's talk about that collateral damage. We talked about the potential for QT prolongation. That's more with moxifloxacin, and then the G6PD deficiency patients and hemolytic anemia. So I just gave you, I didn't even get into the inducing resistance. I just gave you about 10 good reasons not to use these drugs. So we don't use them in pregnant women, but I do want to read this FDA statement. And if you don't get anything out of this, I want you to get this. Healthcare professionals should not prescribe systemic fluoroquinolones to patients who have other treatment options for acute bacterial sinusitis, acute bacterial exacerbations of chronic bronchitis, COPD exacerbations, uncomplicated urinary tract infections, because the risk outweighs the benefit to these patients. When you read that FDA warning, you just became culpable if any of this happens. And you do it. You can't say you weren't warned. But anyway, because of the overuse, we've lost the reliability for a lot of our gram-negative pathogens, specifically E. coli. So a lot of times we can't use these other than for CAP, community-acquired pneumonia, unless we have a definitive culture and sensitivity for those reasons. But again, you can look at the doses, but look at this. Excellent IV to PO options. And this gives you, with levofloxacin, we're talking 1-to-1. Just very, very nice. So anyway, we're going to stop there with Bactrim. So I'll stop my share. We're going to stop the recording here. That was a lot of information, but this will end week 2 with lecture 2. Week 2 is done.